Okay, moving on to testicular tumors. My recommendation before you do this section would be to make sure that you master the section on female ovarian tumors. And that's because once you understand ovarian tumors, testicular tumors are all downhill. Now remember that in the female ovary we had three compartments that could lead to tumors. We had the surface epithelium, which created surface epithelial tumors. We had the germ cell leading to germ cell tumors. And then we had the sex cord stroma, which was the connective and supportive tissue of the ovary, which leads to sex cord stromal tumors. Now fortunately within the testicle we don't have surface epithelium, so that makes life a little easy. And so therefore there are only two types of testicular tumors. There's the germ cell tumor and then the sex cord stromal tumor. Patients with testicular tumors, they present with a firm, painless testicular mass, and of course because it is a solid, firm mass, it cannot be transluminated. Again, this is in contrast to a hydrocele, which would be transluminated. Now, one very high yield and important point to recognize is that testicular tumors are not biopsied. This is against the general principle of medicine where you always biopsy cancer to prove that it's cancer and to subtype the cancer. However, in the case of the testicle, this is not performed for two basic reasons. Number one, if this is the testicle sitting in the scrotum, if a biopsy were performed, you would pull the tumor out from the testicle and potentially seed the scrotum. And of course, that would not be desirable. So that's the first reason why we don't biopsy testicular tumors. The second reason why we don't biopsy testicular tumors is that the vast majority of testicular tumors are actually germ cell tumors. In fact, greater than 95% of testicular tumors are germ cell tumors, and germ cell tumors are all malignant. So for all practical purposes, the vast majority of testicular tumors are malignant. Germ cell tumors, as I just mentioned, are the most common type, greater than 95% of testicular tumors. They usually occur between the ages of 15 to 40. Risk factors include cryptorchidism, or an undescended testicle, and Klinefelter syndrome. Let's go back and just briefly remind ourselves, as we spoke about when we talked about the female ovary, that there are really 5 key germ cell tumors to be familiar with at your level. Remember that the germ cell has the ability to make baby tissues, and so therefore you can get tumors of baby-like tissues. For example, the teratoma, which would represent mature baby tissue, and embryonal carcinoma, which would represent embryo-like cells. And then in addition, the germ cells have the ability to make placenta. And when you get a tumor of placental tissue, that's called a choriocarcinoma. The germ cells also have the ability to make yolk sac, and so when you get a tumor of yolk sac, that's called a yolk sac tumor. And finally, the germ cells have the ability to make additional germ cells. Now, in the ovary, that was called a dysgerminoma. However, in the testicle, that is called a seminoma, seminoma, as if it contains sperm or germ cell-like cells. Now, in the case of germ cell tumors within the testicle, remember that all are malignant. And we divide germ cell tumors into seminoma and non-seminoma, and this is a major division in our understanding of germ cell tumors. And that's because seminoma usually responds to radiotherapy, metastasizes late, and has an excellent prognosis, versus non-seminoma, which has a variable response to treatment and metastasizes early. So we're going to first start with seminoma. Seminoma, of course, is a malignant tumor of large cells with clear cytoplasm and central nuclei. In fact, this description is very similar to the description of dysgerminoma within the ovary. And so seminoma in the testicle equals dysgerminoma within the ovary. Now, when a seminoma is present, the gross examination of the testicle will reveal a homogeneous mass with no hemorrhage or necrosis. This is high yield. Examiners like to ask you this. So that the mass itself will be homogeneous with no hemorrhage and no necrosis. And I'll show you a picture of this in a moment. Rare cases of seminoma can produce beta-8-CG. Now remember that we classically associate beta-8-CG with choriocarcinoma or the tumor of placental tissue. However, rare cases of seminoma can also produce beta-8-CG. And we have already discussed the fact that seminoma has a good prognosis and responds to radiotherapy. Here's a picture of seminoma. What we have here are large cells with clear cytoplasm and central nuclei, and of course the dysgerminoma in the ovary would look very similar. Here's the gross picture of a seminoma. Recall that it is a homogeneous mass with no hemorrhage and no necrosis. And again, examiners like you to know that it is a homogeneous mass with no hemorrhage and no necrosis. As far as the non-seminomatous tumors are concerned, the first that we'll discuss is embryonal carcinoma. Remember that we're going to divide testicular tumors into seminoma and non-seminoma. So now we're talking about the non-seminomas. The first would be embryonal carcinoma. Again, this is a malignant tumor of immature primitive cells. Again, they're embryo-like, hence the word embryonal. They're very primitive, like the cells of the embryo. It is important to note, and examiners like to press on this issue, and that is that the tumor can form glands. It's going to be a hemorrhagic mass with necrosis, and that's because it's a primitive tumor and is rapidly growing. It'll be bloody, it'll be necrotic. This tumor is aggressive with early hematogenous spread. Again, the cells are primitive and embryo-like, and so they're genetically programmed to move and spread rapidly. When patients with embryonal carcinoma are treated with chemotherapy, an interesting thing that can occur is that the tumor can differentiate. So because these are very primitive embryo-like cells, that tumor can actually become something more mature. For example, chemotherapy can cause the embryonal carcinoma to become a teratoma, and that's particularly high yield for board examinations as well. Now, embryonal carcinoma is very primitive, and it also has the ability to secrete alpha-fetoprotein, or beta-HCG, and that again is important to note. Classically, you would associate AFP with yolk sac tumor, and classically you would associate beta-HCG with choriocarcinoma, the tumor of placental tissue. However, it's important to note that embryonal carcinoma can secrete either AFP or beta-HCG. Here's a picture of embryonal carcinoma. You've got primitive cells, and in this particular case they're forming glands. And I thought this was a perfect picture because, again, examiners like you to know that embryonal carcinoma does have the ability to form glands. Here's a gross picture. This is the tumor here in the testicle. Again, this is the normal up here, and you can clearly see that this is a hemorrhagic or bloody mass. And again, that's indicative that you're dealing with a non-seminomatous germ cell tumor, and in this particular case, embryonal carcinoma. Yolk sac tumor is a malignant tumor that resembles the yolk sac. It's the most common testicular tumor in children. That's high yield. So for your purposes, when you have a testicular tumor in a child, for example, a 5-year-old, then you really want to consider yolk sac on the top of your differential. Now, of course, yolk sac tumor has the ability to produce alpha-fetoprotein, and so AFP is characteristically elevated in yolk sac tumors. The characteristic histology of yolk sac tumor is called a Schiller-Duval body. Now, this isn't the most common histology, but it's the classic characteristic histology, and hence it shows up on examinations. This is also called a glomeruloid-like structure. That's the way the examiners like to describe it. Again, a glomeruloid-like structure. And the idea here is that this sort of mimics the glomerulus. Let's pretend that this is Bowman's capsule, and this is Bowman's space, and then this is the glomerulus with a blood vessel running through it. Again, it doesn't exactly look like the glomerulus, but it's glomerulus-like. And so therefore it's called a glomeruloid structure. And again, those are called Schiller-Duval bodies, and they're characteristic for yolk sac tumor. Choriocarcinoma is a malignant tumor of placental-like tissue, and so it contains the cells that normally line the placental villi, and those are syncytiotrophoblasts and cytotrophoblasts. Now, remember that the syncytiotrophoblasts are going to make beta-HCG. It's high yield to know that the beta-HCG comes from the syncytiotrophoblasts. Now, when the beta-HCG is made by this tumor, that's going to result in elevation of the beta-HCG. However, another important thing to remember is that when you have a high beta-HCG, the alpha subunit of HCG is similar to the alpha subunits of FSH, LH, and TSH. And therefore, patients can present with hyperthyroidism because the HCG can activate the TSH receptor, or gynecomastia because the HCG can activate the FSH and LH receptors. And that's very high yield for the purposes of examinations. Now, this tumor is going to produce syncytiotrophoblasts and cytotrophoblasts, so it mimics placental tissue. However, remember that the functional unit of the placenta was the villus, so that when you look at a placenta, you've got a villus with a blood vessel running through the center, and then you've got these syncytiotrophoblasts and cytotrophoblasts growing around the edge. However, in the case of choriocarcinoma, it's very important to note that you don't get villi. You only get the syncytiotrophoblasts and the cytotrophoblasts. Now, of course, syncytiotrophoblasts and cytotrophoblasts are genetically programmed to find blood vessels. That's what the placenta does when it implants into the uterine wall. And so this tumor will metastasize very early via the blood. In fact, one of the characteristics of this tumor is that you tend to have a tiny primary within the testicle and then massive tumor throughout the rest of the body. And that's a little bit against the convention when we think about cancer. Remember, if the patient's got, for example, a large breast mass, and a tiny mass in the liver, then we would assume that the breast mass is the primary and that the tiny mass in the liver is probably metastatic from the breast. However, in this particular case, you have a tiny mass in the testicle and massive disease throughout the rest of the body, but because you know that choriocarcinoma rapidly goes into the blood, you can assume that the primary is actually in the testicle. So again, that's important to note as well. Here's a picture of choriocarcinoma. These are the cytotrophoblasts, and these larger cells, multinucleated, are the syncytiotrophoblasts, and again, there would be no villi produced by this particular tumor. Teratoma is the final germ cell tumor. This is a tumor of mature fetal tissue. It's derived from 2 or 3 embryonic layers. Now, very high yield to note, teratoma was benign in females. However, in males, it is malignant. All right, teratoma is benign in females. However, in males, it is malignant. And teratoma can also produce AFP or beta-HCG. So these are a few high yields to be aware of concerning teratoma. Now, although we spend so much time dividing germ cell tumors into these very distinct categories, the vast majority of germ cell tumors are usually mixed. So, for example, a patient can have a yolk sac tumor plus a choriocarcinoma, or a teratoma plus a seminoma. And so it's important to remember that most germ cell tumors in the testicle are actually mixed. And the prognosis is based on the worst component. So, for example, if you have a seminoma and associated with that seminoma is a choriocarcinoma, then the prognosis would be based on the choriocarcinoma. Sex cord stromal tumors are the second category of tumor that can arise within the testicle. These tumors resemble the normal sex cord stromal tissues of the testicle and are usually benign. Here's an image of the normal testicle just to remind you of the sex cord stromal tissues. So the sex cord includes the Sertoli cells, and remember that the Sertoli cells are the cells that line the tubules, and of course this area here is the tubule. So you could potentially get a Sertoli cell tumor. At the same time, you've got these pink cells in between the tubules, which are called Leydig cells, and so you can also develop a Leydig cell tumor. Now, Leydig cell tumors usually produce androgen, and so because they produce androgen, you're going to get precocious puberty in children, or it could also result in gynecomastia in adults. One of the characteristics on histology of a Leydig cell tumor is that you see these crystals within the cells, and these are called Ranke crystals, and that's, again, high yield to know that Leydig cell tumors often have Ranke crystals. Sertoli cell tumors will be composed of tubules, and of course the Sertoli cells are the cells that normally line the tubules, so the tumor of Sertoli cells will also form tubules, and these are usually clinically silent. The final point to make in this section is that when you have a testicular mass in the testicle, it's of course usually a germ cell tumor, but that germ cell tumors normally occur between the age of 15 to 40. If you have a testicular tumor in a male greater than the age of 60, for example, then the most common cause would be lymphoma. Again, it's important to note the age of the patient. 15 to 40, you think about germ cell tumors, but greater than the age of 60, the more common cause of a testicular mass is lymphoma. This is usually bilateral, and the lymphoma that develops in the testicle is usually a diffuse large B-cell type of lymphoma. And that concludes our section on testicular tumors.